and
you.
I'll unblank the screen for you.
Oh.
That's a
Oh, I
nice
didn't
little nice little tip. So if you're doing things that you are signing into things and you don't want students to see,
Oh, I didn't know you could do that.
yeah.
Oh, great.
I'll be
Oh, yeah,
nice
sure.
and close to that
Thank
if
you.
you
I appreciate it. Thank you. All right, so I think I'll get started. So if you all could go to rwpoll.com, the session ID is Endo Review 2015. And since there are some people here who I don't recognize, I was going to introduce myself, but I thought I would start with a question. This is not on the polling, but it's who am I? Because I have not seen some of you before ever in my entire life, and I usually sit right in the front of the class. So am I Dr. Garrett? And I hope you know that this is Dr. Garrett. It's a good picture of him. B is I don't know and I don't care, and I've already fast-forwarded the recording past this question. C is I don't know, but I think I've heard your voice before on one of the lecture recordings. And D is the right answer. So I'm Salila Kerr, I'm the section director for here. And there are about, I think, 10 questions, and some of them are followed by long, detailed explanations. So why don't we just get started? So the first question is, Cushing's syndrome caused by pituitary adenoma could be best differentiated from ectopic Cushing's syndrome caused by lung cancer using which of the following tests? right, so why don't you pick an answer and I'll close the polling. So if you just pick anything. When in doubt, you could always go with C. All right, so I'm going to close the polling. And it seems like most people picked A as the right answer. And the right answer is A. It's the 8 milligram dexamethasone suppression test. So let's just go over Cushing's in more detail. So in order to diagnose Cushing's, you have to, 1, suspect it on the basis of the patient's symptoms and signs, 2, document hypercortisolemia, and 3, determine its cause. So I'm just going to go into detail about each of these. So the first is suspected on the basis of the patient's symptoms and signs. So this is a patient, or a cartoon of a patient with Cushing's. So as you can see, some of the things that are affected, you have emotional disturbance. If you have Cushing's from a pituitary source, you have an enlarged cella turcica. You could have a Moon facies. You can have osteoporosis because you're secreting steroids, which uncouple bone and you have more resorption than building. You can get cardiac hypertrophy and hypertension. You can get a buffalo hump, abdominal obesity, and if the Cushing's is from the adrenal gland, you can get an adrenal tumor, and you can see skin findings as well, and then you see skin ulcers. So the most common feature is this progressive central obesity, usually involving the face, neck, trunk, and abdomen, and the extremities are usually spared and maybe wasted. The loss of subcutaneous connective tissue is due to the catabolic effects of glucocorticoids, which result in easy bruising even with minimal injury. You get purple striae because the skin is fragile and stress is due to the enlarging trunk, breast, and abdomen. And osteoporosis, as we talked about, is common in patients with Cushing's. And glucose intolerance or prediabetes is common in Cushing's syndrome, and it's primarily due to stimulation of gluconeogenesis by cortisol and also from the peripheral insulin resistance that is caused by the obesity. And you also have hypertension and cardiovascular disease, and lastly, you have increased mortality. So now that you've suspected it based on the patient's signs and symptoms, the next thing to do is to document hypercortisolemia. So the screening test is one of these two tests. You can have a patient collect 24-hour urine for free cortisol, or you can do a 1 milligram overnight dexamethasone suppression test. And the way that's done is you give the patient 1 milligram of dexamethasone at 11 p.m. the night before, and at 8 a.m. you check their cortisol. And the cortisol should be less than 2, and this is because you have negative feedback. Dexamethasone is a potent steroid. When you give it to someone, it goes back to their pituitary and suppresses ACTH, which then should suppress endogenous cortisol. So you should have a cortisol less than 2. And once you've done these tests, if you did the 24-hour urine to screen, you could do the 1 milligram dex to confirm. And if you did the 1 milligram dex to screen, you could do a 2-day low-dose dexamethasone test to confirm. Once you've confirmed, the next thing you need to do is to determine its cause. And the way you determine the cause is you check the ACTH. You know the patient has Cushing's, but you don't know where it's coming from. So when you check the ACTH, it's either ACTH mediated or it's non-ACTH mediated. So in the ACTH mediated situation, the ACTH is normal or high, and in the non-ACTH mediated, the ACTH is low. And I'll talk about the ACTH mediated on the coming slide, but I'm going to briefly talk about the non-ACTH mediated. So since the ACTH is low, you know it's not from the pituitary and it's not ectopic. So there's only one other place it can be from, and that's the adrenal. And the adrenal sources, you either have an adenoma, a carcinoma, or hyperplasia. And the way that you sort this out is you get imaging the adrenal glands and you get a CT scan. The other situation where you see a high cortisol and a low ACTH is from exogenous glucocorticoids, which can also cause this. So you want to determine the cause also when it's ACTH mediated, and you want to differentiate between pituitary and ectopic, both of which are mediated by excess ACTH. It's important to remember that even when you have a known pituitary adenoma, 50% of people can have normal MRIs. So having a normal MRI does not rule out pituitary Cushing's. The important other thing to remember in what this question addressed is the fact that pituitary Cushing's is still susceptible to negative feedback. So you don't really get negative feedback when you only give 1 milligram of dexamethasone, but if you use a high dose of dexamethasone, in this case 8 milligrams, then you do get negative feedback and you get suppression. So pituitary Cushing's is still suppressible by using dexamethasone, whereas ectopic does not suppress to high dose dex. And you can also do a petrosal sinus sampling to find out the location, which side of the pituitary it's in. And with regards to ectopic, most ectopics are from small cell carcinoma of the lung, but you can also see it with carcinoid. Again, it does not suppress to high dose DEX, and it is not stimulated by CRH because it's outside of the HPA axis. And another important point is that it can present with hypokalemia. This is because the ACTH levels are so high that your cortisol levels are also high, and you get mineralocorticoid effect both from the high cortisol levels and from the fact that you have the precursor, which is a potent mineralocorticoid. So I wanted to move on to the next question. It's a 49-year-old woman who's diagnosed with Graves' disease with the following physical exam findings. It's the eyes, in case you're wondering. Treatment should be initiated with which one of the following? All right, so if you could just please pick an answer, and then we'll close the polling. All right, so I'm going to close it. And 79% picked C, and the answer is C. So just to briefly review this, the treatment for Graves' disease, methimazole and PTU, the way that they work is they inhibit thyroid hormone synthesis and they block iodination. Methimazole is the first-line treatment, and why it's the right answer over PTU is because in June of 2009, the FDA issued a black box warning regarding the dangerous risks of liver failure and death. And prior to that black box warning, other than acetaminophen and INH, PTU used to be the third leading cause of drug-induced liver transplantation. So since then, we rarely use it and really only use PTU in the first trimester of pregnancy. But otherwise, methimazole is the first-line agent. The reason we wouldn't give this patient I-131 is because she has Graves' eye disease, and the radioactive iodine can worsen the Graves' eye disease. So moving on to the next question. A 52-year-old man goes to a new physician for a checkup. He feels fine and is taking no medications. He last saw a doctor 5 years ago, at which time he was told that his examination was normal, as is his current evaluation. The physician orders a panel of tests, and the serum calcium is 10.9, which is high, and his bone-specific alk phos is 120, which is also high. A chest x-ray is normal. Which of the following statements is most likely correct? All right, so if you could pick an answer, then I'll move on to the explanation. Okay, so if you just pick anything. All right, so the answer to this question is yes, so 56% of you picked the right answer. It's the bone density studies of the lumbar spine will be normal. So just to go over this in more detail, the key points are parathyroid hormone has preferential catabolic effects on cortical bone, so that's your distal radius, and relatively sparing effects at the trabecular cancellous bone, which is your lumbar spine. So most people with primary hyperparathyroidism or excess parathyroid hormone have normal lumbar spine bone densities. And primary hyperparathyroidism most commonly presents as an asymptomatic patient. If you remember from Dr. Belazikian's lecture, he showed you the picture of Captain Charles Martel, who had multiple lumbar compression fractures and was essentially peeing out gravel because he had so much calcium in his urine. That was how people used to present. And then in 1970, when we all started getting Chem-10s and we would get calciums on everybody, we would now find hyperparathyroidism long before anyone has a symptom. So the important take-home point is that parathyroid hormone affects cortical bone more than it affects other types of bone, and that usually patients are discovered asymptomatically and just by having an abnormal lab value. So if you see hypercalcemia, so the calcium is high, the next thing you do is check the PTH. So I just learned how to do animation, so bear with me. You're going to see lots of it. And if the PTH is normal or high, then it's parathyroid mediated. So that's an important point to remember. If you have a high calcium and your PTH is normal, that is not normal. It's inappropriately normal because your PTH should be low if your calcium is high. So if you see a normal or high PTH, then you can move into the category of hypercalcemia that's parathyroid mediated. The differential for this includes primary hyperparathyroidism, which is the leading reason to have a parathyroid-mediated hypercalcemia. And there's also familial hypocalciuric hypercalcemia, which is a very rare cause, but in the differential. And if the PTH is low or undetectable, it's a non-parathyroid-mediated hypercalcemia. And the differential for that is, and I put it in bold on purpose, is malignancy. And the other things in that differential are granulomatous disease, vitamin D intoxication, medication-induced, in particular thiazide diuretics can do this, as can lithium, and immobilization. Actually, I'm sorry, thiazide diuretics usually more so do it through a parathyroid-mediated process, as does lithium, but other medications can cause non-parathyroid-mediated. You can also see it with immobilization. You can see it with thyroid disease and adrenal disease. So what you really should be looking for are you should get a chest x-ray and a PTHrP, which is a PTH-related protein, which will tell you if it's because of malignancy. The chest x-ray will tell you if you have lung cancer, which is a main cause of hypercalcemia in a patient who has cancer. And it will also tell you if you have a granulomatous disease, such as sarcoid or TB. And the TSH is to look for thyroid disease. In particular, hyperthyroidism can lead to hypercalcemia. And SPEP is to look for multiple myeloma, which is a type of cancer. So basically, the important take-home point is that if you have hypercalcemia, you need to figure out the PTH, and then based on the PTH level, you can separate it into one of these two categories. So the treatment of hypercalcemia should be aimed at both lowering the serum calcium concentration and treating the underlying disease. And the stars and the bold and the all caps is to reiterate the important point that the main first thing that you should always do in a patient with hypercalcemia is give fluids. These patients are hypovolemic, which exacerbates the hypercalcemia and worsens the renal clearance of calcium. When you see a patient with a life-threatening high calcium, the treatment of choice is fluids first. And that was one of the questions on the TBL today, and that's why it's a very important point to know that you have to give fluids. The other treatments include, after you've given fluids, you can give a loop diuretic, such as furosemide, which will increase the urinary clearance of calcium. You can give calcitonin, and when you give calcitonin, since calcitonin only works for about 2 days, you can also give an IV bisphosphonate, such as zoledronic acid or permidronate, which doesn't work for a couple of days. So until the bisphosphonates kick in, you should be using calcitonin. And it's important to note that only IV bisphosphonates lower serum calcium. The PO bisphosphonates that we talked about in lecture today that are used for the treatment of osteoporosis do not lower your serum calcium and have no role in the treatment of hypercalcemia. And then depending on the cause, you can also use glucocorticoids. So if somebody has sarcoid or certain types of cancer, then the glucocorticoids, especially if the hypercalcemia is mediated by 125D, the glucocorticoids can be used in that setting. So a 29-year-old man presents to his physician with nipple discharge of 3 weeks duration. His review of symptoms is negative. He has previously been healthy and is taking no medications. Watery fluid can be expressed from both nipples. The remainder of the physical exam is normal. He has a serum prolactin of 124, which is high. His brain MRI is shown. He is most likely to have which one of the following lab values? So if you can just remember, because I couldn't figure out how to put this on a PowerPoint slide, what your answer is and the MRI for the next slide. So the MRI is not on the next slide, but the question still is. So. All right, so if you want to wrap it up and pick a answer. All right. So most people, about 60%, picked E, and E is the right answer. So let's just go over the key points. So this patient has a prolactinoma, and prolactinomas often present with amenorrhea or menstrual irregularities in women because prolactin inhibits GnRH and also FSH and LH. And you get low testosterone levels in men for the same exact reason, because prolactin inhibits GnRH, FSH, and LH. It often presents with galactorrhea, and it may present with temporal visual loss or bitemporal hemianopsia. You really should know that this is what bitemporal hemianopsia looks like. This is caused by compression of the optic chiasm, which sits right above the pituitary gland. And it does not commonly present with DI or diabetes insipidus because those cells are in the posterior pituitary, and prolactinomas rarely affect the posterior pituitary. So the main take-home points are that if you have a prolactinoma in a woman, she's not menstruating because the prolactin's suppressing her gonadotropes, and in men it presents with low testosterone. And that you need to, anyone with a pituitary mass, you should make sure that they do not have these visual field deficits. And the first line treatment is medical therapy with a dopamine agonist. Dopamine inhibits prolactin secretion, and normally you get the constitutive secretion of dopamine, and that keeps prolactin at a normal level. So the way this is treated is by giving a dopamine agonist. So a physician wishes to treat a patient with type 2 diabetes with a medication which inhibits dipeptidyl dipeptidase 4, DPP4. The medication is which one of the following? All right, so it looks like almost everyone's picked. If you haven't, just go ahead and pick something. All right, so yes, so it is sitagliptin. So let's just go over the treatments for diabetes. So metformin is the first-line agent for type 2 diabetes. It is not the first-line agent for type 1. The first-line agent for type 1 is insulin because they're insulin deficient, and because they don't have insulin, that's the treatment of choice for type 1. So for type 2 diabetes, and that's what I'll be talking about for the rest of these diabetes treatment-related slides, the first line is metformin, regardless of which algorithm you look at. And I know Dr. Donovan showed some of the algorithms that we use, but in all of them, metformin is the first choice for the treatment of type 2 diabetes. And other than lowering A1C, it also leads to moderate weight reduction. And it can be used as monotherapy, and when it is, it almost never causes hypoglycemia. And it's contraindicated if the creatinine is greater than or equal to 1.4 in women or greater than or equal to 1.5 in men. And this is just a graphic I stole from somebody else on the internet. and it looks at what metformin does at different organ systems. So in the liver, it decreases gluconeogenesis and improves insulin sensitivity. In the GI tract, it decreases food intake, and this is adipose tissue, and it increases glucose uptake and oxidation in the adipose tissue. And at the skeletal muscle, it increases glucose uptake. So the net effect is it improves your blood glucose and lowers your A1C and also lowers your weight. So the incretin effect, and the two classes of drugs that take advantage of the incretin effect are GLP-1 agonists and DPP-4 inhibitors, which sitagliptin is a DPP-4 inhibitor. So the actual incretin effect is the fact that you secrete incretins in a much larger response to an oral glucose load than to an IV glucose load. So we take advantage of this because then you get a glucose dependent insulin release. That's how GLP-1 works. So, and it reduces your food intake. And the way that it reduces your food intake is that in the hypothalamus, it decreases your appetite and makes you feel more satiated, which then leads you to take in less food. It also works at the stomach to decrease acid secretion, and it works in the endocrine pancreas by increasing beta cell insulin secretion. And it works at the muscle by increasing glucose uptake. So the DPP-4 is a ubiquitous enzyme that's expressed on the surface of most cell types that deactivates a variety of other bioactive peptides such as GIP and GLP-1. So the two ways that you can affect the system are by having a GLP-1 agonist or by inhibiting the enzyme that breaks down GLP-1. So the DPP-4 inhibitors, unlike the GLP-1 agonists, are administered orally, whereas the GLP-1 receptor agonists are sub-Q injections. So the main take-home point about the incretins is that they do not cause hypoglycemia because they only are stimulated when you have glucose, and that they, at least the GLP-1 agonist, because of the effects in the hypothalamus, can lead to weight loss, whereas the DPP-4 inhibitors are weight neutral. And the other diabetes treatments that we don't, probably aren't as popular are glipizide, which is a sulfonylurea, and it's insulin secretagogue. And what that means is it stimulates insulin release from the beta cell in the pancreas. And as you would expect, because it's stimulating insulin release, and unlike the incretins, it's not glucose-stimulated insulin release. Regardless of what your blood glucose is, if you take a secretagogue, you will make insulin. So the major side effect of sulfonylureas is hypoglycemia. And acarbose is an alpha-glucosidase inhibitor, and it causes delayed hydrolysis of ingested complex carbohydrates and disaccharides and absorption of glucose. And it's pretty potent at lowering your A1C, but because of its mechanism of action, it causes a lot of flatulence, and for obvious reasons, people don't like to use it. And then there's pioglitazone, which lowers your blood glucose concentration by increasing insulin sensitivity. But the most important ones to know are metformin and how it works, and the incretins. And then for type 1 diabetes, you should know about which insulins we use. So a physician decides to treat a patient with osteoporosis with a bisphosphonate drug. The patient should be told which one of the following. All right, so why don't we pick something? All right, so I'm going to close polling. And 65% picked B, some oral formulations can be taken monthly, and that is a true statement. So let's just talk a little bit more about osteoporosis. So osteoporosis is caused by the cumulative effect of bone resorption and excess of bone formation. So basically, all that says is you're breaking down more bone than you're making. If you're 15 and growing, you're making more bone than you're breaking down. But if you're 65 and postmenopausal as a woman or over 70 as a man, you're more likely to be breaking down bone than to be making bone. And osteoporosis is defined as a T-score. So a T-score is the bone density of your patient compared to a woman at peak bone mass. So that's a 30-year-old woman. And if it's less than or equal to minus 2.5 on the bone density, then you have a definition of osteoporosis. And what that means is that that patient is at increased risk of fracture. Or you can get the diagnosis of osteoporosis if you have a fracture, such as a vertebral fracture or any other fragility fracture. And I'll go over exactly what a fragility fracture is. And that's important to know that even if you have a normal T-score, you can still have osteoporosis if you break a bone or in your spine or you have a fragility fracture. So the people that should be screened with a bone density are all women over the age of 65 and all men over 70. And you should look at postmenopausal women and men older than 50 if they have a non-traumatic fracture after age 50. So examples of non-traumatic fragility fractures are if you're walking down the street and you trip and you break your wrist, or if you're lifting, opening a window and you break a vertebral bone. Those are all fragility fractures. So the definition of a fragility fracture is a fracture from low trauma or a fall from a standing height. If you ski into a tree, that is not a fragility fracture, that's a high trauma fracture. So it's important to ask people the clinical history. If you're getting off the lift and you fall forward and you break your wrist, that is a fragility fracture. And I always fall getting off the lift, so don't sit behind me. But, and the risk factors for osteoporosis are smoking, a family history of osteoporosis, low body weight, and in particular weight less than 127 pounds. If you're on long-term glucocorticoids, so anything over 3 months is considered long-term, or premature menopause, so menopause before the age of 40. So who should be treated? So anyone with osteoporosis by the DEXA definition, which is a T-score less than or equal to minus 2.5, the presence of a fragility fracture, so anyone who fell from low trauma or from a standing height, and anyone who meets the FRAX tool, which Michelle Rubin went over in great detail in her lecture today, so take a look at that. But anyone, when you put into the algorithm their risk factors, if they meet a 10-year risk of any fracture that's greater than 20% or a hip fracture that's greater than 3%, they should also be treated. And then the first-line treatment are bisphosphonates, and bisphosphonates inhibit bone resorption, and they're the most widely used medication for the treatment of osteoporosis. And most bisphosphonates must be taken on an empty stomach for maximal absorption. There's one new drug that does not need to be, but most of them do. Some are more potent than others, so IV zoledronic acid is the most potent of the bisphosphonates. And there are absence of clinical trial data regarding ibandronate with regards to hip fracture. So that's why that answer choice was not correct. And the common side effects include GI side effects, including dysphagia, esophagitis, and ulcer, and musculoskeletal pain. And the less common adverse associations with bisphosphonates are the following. Does anybody know what this is? Yes, it's an atypical fracture. We call it a chalk break because it breaks like a piece of chalk. And these are the two parts of her femur or his femur. And this is it's a subtrochanteric hip fracture. And there's a theoretical concern that prolonged therapy leads to over-suppression of bone turnover. So the mechanism of action of bisphosphonates is that they suppress bone turnover. But we worry that they can do it a little bit too well, especially if you keep it on for 5 years or longer, and then lead to actually more delicate bone that then can fracture like this. And you can actually get increased skeletal fragility. So that's what Dr. Belzikian was referring to today when he said many times after 5 years, we'll put people on a holiday and just hold the medicine so that this doesn't happen. And does anybody know what this is? This is a mouth. Yeah, so it's osteonecrosis of the jaw, also known as aseptic necrosis, and it's another very rare side effect. And like Dr. Belzikian said in his lecture today, it's like getting struck by lightning. Not in New Mexico, because apparently a lot of people get struck by lightning in New Mexico, but it's like getting struck by lightning in New York. So a 37-year-old woman presents with inability to conceive despite regular intercourse for the last 2 years. She has had irregular periods with several days of vaginal bleeding every 3 to 4 months. She's 5 foot 8 inches and weighs 210 pounds, which is a BMI of 32. She has increased facial hair and acanthosis on the neck. She is most likely to have which of the following panels of serum lab results? If you could just remember your answer, and then I'll move to the other slide in a minute, and then you can pick what you think is the right answer. All right, so if you remember your answer, is everybody okay with me moving to the next slide? Yes? Okay. So if you can remember your answer and just choose it. All right. So I don't actually remember the answer, so we'll go to the next slide and see. Okay, so I'm going to stop polling. Oh, okay. So I actually don't remember which one the right answer is, so let's move to the next one. The right answer is A. So you get increased LH and FSH ratio, and I'll go over this in more detail because clearly there's a little bit of confusion about it, so we'll go over it in a little detail here. And you get increased estrogens, increased androgens, and decreased SHBG, which is sex hormone binding globulin. So the key points regarding polycystic ovarian syndrome, and since basically in all the lectures we told you we don't really understand exactly what happens with PCOS, but these are the things that we do know and that you should know. So PCOS is characterized by, and you need 2 of these 3 criteria. You need either hyperandrogenism, so you need either blood work that has elevated testosterone or signs of androgen excess on exam, such as excess hair or clitoromegaly or something else that shows that you have excess androgen. Or you need irregular menses, so oligo or amenorrhea. And remember, oligomenorrhea is less than 9 periods a year. Or you need this appearance on a transvaginal ultrasound or any ultrasound, and this is the string of pearls, and these are cysts in the ovary. So by the Rotterdam criteria, if you have 2 of these 3 things and you've excluded all other causes for hyperandrogenism and irregular menses, then you have PCOS. And insulin resistance is a part of the PCOS pathogenesis. Insulin stimulates ovarian and androgen production in the theca cell. So let me just say it again in a different way. So this is a cartoon from the New England Journal of Medicine, and they did a review on PCOS. And what they show here is that in the hypothalamus, the GnRH pulse generator fires too much. So if you can see, these are normal pulses, and then these are this is what happens in PCOS, at least this is what we think happens, is that the pulse generator goes too fast, which then leads in the pituitary to an increased LH to FSH ratio. So classically, we think these patients have 3 times as much LH as FSH. And then what happens is, because you have too much LH, you get increased androgen production in the theca cells of the ovary. And you also get increased aromatase activity in the granulosa cell from the increased FSH. And then lastly, insulin resistance causes the insulin to stimulate androgen production in the ovary as well and inhibit sex hormone binding globulin. And when you inhibit sex hormone binding globulin, you increase the amount of free testosterone. And then that's why you have excess androgen. So it's this whole cascade that leads to that. And then the liver also lowers SHBG production, so there are even higher levels of free androgen. So the main take-home points are that you have much higher levels of androgen, and as a result, you also have irregular menses. So people with PCOS usually present with less than 9 periods a year and signs of androgen excess. So with regards to the treatment of PCOS, you really have to break it down into 2 categories. Either fertility is desired or fertility is not desired. If fertility is not desired, the treatment of choice is oral contraceptive pills. If somebody wants to get pregnant, obviously they shouldn't take an oral contraceptive. So if no fertility is desired, you can give just an oral contraceptive, or you can give an oral contraceptive and metformin, because metformin improves the insulin resistance. And as we talked about in this slide, insulin resistance is an integral part of the pathophysiology of PCOS. So if fertility is desired, then we can use a selective estrogen receptor modulator, and in this case it's clomiphene citrate. And what it does is it works as an agonist at the hypothalamus. And as we stated in this slide, one of the problems is the GnRH pulse generator is abnormal. So if you use Clomid, you can normalize that and then have a normal LH to FSH ratio. And then you can also use metformin if fertility is desired, because when you improve the insulin resistance, you decrease androgens, and many women can menstruate normally just with metformin. All right, so a 12-year-old boy is brought to the emergency room. This may look familiar to you because you just had this on your test last week or earlier this week. So a 12-year-old boy is brought to the ER by his parents because he's been drinking water constantly and urinating every 30 minutes for the last 12 hours. He's previously been healthy. His temperature is 98.7, blood pressure 95/70, heart rate of 120, and respiratory rate of 26. He has an odor of acetone on his breath. His lungs are clear to auscultation and percussion. His urine is 4+ for glucose. Which one set of serum electrolytes is most likely for the patient? And again, if you could please remember the answer, so when we move to the next slide, you can put it in. Actually, let me see if, no, I didn't. So if you could please remember the answer, and then I'll go to the next slide. Just tell me when you're ready. All right, kind of looks like everyone's ready. Oh, no, you're not? Okay, my bad. Sorry. All right, is everyone ready for me to move on? All right. So the correct answer is E, and let's go over why. So DKA, or diabetic ketoacidosis, there's a total body potassium deficit. Almost all patients with DKA have a substantial potassium deficit due to urinary and in some cases GI losses. However, because of the shift of potassium out of the cells, due primarily to the insulin deficiency and hyperosmolality, the serum K is often elevated at presentation. But you need to remember this when you're in the hospital next year, actually, I guess in 6 months, that when you see a patient with DKA, no matter what their potassium is when they come in, they have a total body potassium deficit. They do not have enough potassium, no matter what their serum K looks like. But the vast majority of them will come in with a high potassium because of the reasons that we have here, because of the shift of potassium out of the cells. And then these patients will also have hyponatremia in the setting of free water shifts and loss of free water. And the ketone bodies have a low pH, so they have a metabolic, an anion gap metabolic acidosis that's initially buffered by the bicarb, but then the bicarb can't keep up and you become acidotic. And you get a compensatory respiratory alkalosis, and people are taking shallow breaths to get rid of CO2 to compensate for the metabolic acidosis. So a patient with primary adrenal insufficiency is most likely to have which set of lab values? Sorry. Are you ready for me to go to the slide where you pick the answer? No? All right. Okay, so if you could please remember your answer and then on the next slide choose it. All right, so I'm going to close the polling. If you just choose. All right, so 72% picked B, and B is the right answer. So let's just go over why. So adrenal insufficiency can be caused by diseases of the adrenal gland, which is primary adrenal insufficiency. So in that situation, you have a low cortisol and a high ACTH. The reason the ACTH is high is because your pituitary is just fine and it's not getting negative feedback. So in primary adrenal insufficiency, your cortisol is low and your ACTH is high. When you have secondary adrenal insufficiency, your cortisol is low, but your ACTH is either inappropriately normal or it's low. And you can also have hypothalamic, but that's not as important. So regarding the diagnosis of adrenal insufficiency, the first thing you need to do is to demonstrate low cortisol secretion. So in normal people, your serum cortisol is highest early in the morning. It's around 8 a.m. And so we take advantage of that because if you check a cortisol at 8 a.m. and it's low, then it suggests that the patient has adrenal insufficiency. And the value that we use is 10. But this is just for screening. You cannot confirm that somebody has adrenal insufficiency just by checking a low AM cortisol, because some people just have lower baseline AM cortisols. So the next thing that you want to do is figure out, yes, they may have a low cortisol, and if they do, why do they have it? So then you check the ACTH. And again, just to reiterate, I know I just had it on the past slide, but it's an important concept to remember, that if the ACTH is high, it's primary adrenal insufficiency, and if the ACTH is normal or low, it's secondary or pituitary. And only with primary adrenal insufficiency do you have loss of mineralocorticoids. And I'll go over this in the coming slides. And this is a very, very important point. If you have secondary adrenal insufficiency, that does not affect the glomerulosa layer of the adrenal cortex, because the main stimuli of mineralocorticoids is not ACTH. It's actually your blood pressure and your serum potassium. And then the last thing you want to do is treat the cause. So the way you diagnose primary adrenal insufficiency after you suspect it by getting this low AM cortisol and the high ACTH is to do a cosyntropin test. This can also be used for the diagnosis of chronic secondary adrenal insufficiency as well. So the way this is done is you check a baseline cortisol, then you give ACTH and recheck the cortisol in 30 to 60 minutes. Now, we just spoke about the fact that these people have a high ACTH, so giving them synthetic ACTH does nothing, and the cortisol doesn't increase. Whereas if you do not have adrenal insufficiency and someone gives you ACTH, your cortisol is going to increase. And if the serum cortisol concentration goes to over 18, then there's no adrenal insufficiency. But the vast majority of patients with primary adrenal insufficiency have a low or flat response to the administration of synthetic ACTH or cosyntropin. So just as a refresher, the three layers of the cortex are the glomerulosa, which makes mineralocorticoids, the fasciculata, which makes glucocorticoids, and the reticularis, which makes androgens. And this is not the cortex, but the medulla makes catecholamines. So again, the main stimulus for mineralocorticoid secretion is not ACTH, so it's not affected during secondary adrenal insufficiency. But in primary adrenal insufficiency, you lose all three layers of the cortex. And this leads to hypotension, in particular postural or orthostatic hypotension. And this is caused by volume depletion resulting from the aldosterone, which is the mineralocorticoid made by the zona glomerulosa deficiency. And this leads to an increase in ADH, which then causes you to retain free water and get hyponatremia. And hyponatremia is found in 85 to 90% of patients with primary adrenal insufficiency. And you also have sodium loss and volume depletion because of the low aldo. And again, one of the major functions of aldosterone is to increase urinary potassium secretion, so you also see hyperkalemia. So just a couple more questions left. So a 37-year-old woman is receiving prenatal care. At her visit in the 5th month of gestation, her fasting blood glucose is 200. Lifestyle and diet counseling is provided. Treatment should be initiated with which one of the following? so let's just close this one up and so we can, because we're running out of time. So the answer is 80% of you picked it is NPH insulin. And the key points regarding gestational diabetes is it's diabetes diagnosed during pregnancy. If you have diabetes before pregnancy or you're diagnosed with overt diabetes during pregnancy, then it's not gestational, you have overt. The criteria for gestational diabetes, the sugars are a little bit lower, so it's any form of diabetes besides true diabetes that's diagnosed during pregnancy. For example, if you have a sugar of greater than 126 when you're pregnant, you have overt diabetes. If you have it between 96 and 125, then you have gestational diabetes. So this is due to increased insulin resistance from placental hormones and weight gain. And the important point here is even after you've delivered, the risk for diabetes is 50% at 5 years, and the lifetime risk is also very high. And it's associated with maternal and fetal risks such as macrosomia. And insulin is the only approved therapy in the United States, and these are the forms of insulin that are approved: NPH, regular, Aspart, Lispro, and Dedamer. And this is the last question, and it's a little bit of pathology since you'll be hearing Dr. Lefkowitz's pathology review in a few minutes. So, which one of the following must be seen to diagnose this thyroid lesion as a carcinoma? So if you can remember which one you're picking, and then it's on the next slide. All right, so if you remember what you want to pick. All right, so B and D were meant to be a little bit tricky. The answer is actually D. It's or, not and. So you need vascular or capsular invasion. So thyroid cancer, papillary is the most common type. It accounts for 80 to 90% of all thyroid cancers. It spreads through the lymphatics and typically presents as an asymptomatic nodule or nodules. You see samoma bodies on pathology. Follicular cancer accounts for 10 to 20%, and you need either capsular or vascular invasion to differentiate an adenoma from a carcinoma. And medullary accounts for only about 5% of cancers and originates from the parafollicular or C cells of the thyroid, and these are the cells that produce calcitonin. And anaplastic, luckily, is very rare. It's only 1 to 3% of thyroid cancers, and it usually arises in older patients and has an extremely poor prognosis. In fact, the 5-year mortality is 100% currently. And it can present with a rapidly enlarging mass in the anterior or lateral neck, and it can cause pain and compressive symptoms. So congrats, I guess this is your last class, and good luck with your exam, and have a nice summer. I guess the battery did not die. Get my stuff out of it. It just died?
That's amazing. That's the best timing.
All right, thank you.
That was really helpful.
Oh, good.
And the phone mic is out of batteries. So I'm going to batteries. I'm looking in the drawer and I'm looking at the keyboard and I see none. All right, thanks so much. nerd.
Oh, that's bad. Say endopath coda review or something like that. That's it. I left my stick in my machine after I went to the trouble of making sure it was in there. Well, in my machine, at least it's in my office. It's on Crossworks. I bet he put it. I'm just doing 3 questions things, and I picked a different variant. Yep. Oh, please. Those darn patients. Thank you.
Would you like this as well? Dr. Leftwood, would you like this?
I'll use it for Should we start? Sooner we start, the sooner you're done. Okay, so I've tried to refocus some of the material we've covered in the lectures and in the labs. There are 3 little quiz questions, so if you don't have a sheet, they're not going to be visible. We're just showing you a picture, as you'll sort of see in your exam if you have pictures, which is likely. And what we'll do is go through the answers to the 3 questions in each section that's applicable. And we're going to cover a little bit at the end on placenta, only for your edification. I don't believe there's anything significant on the exam on placenta, but over at Starbucks around noon today, a 3rd year came up and said, thanks for the lab on placenta, because I really appreciate it now that I'm on OBGYN. So it does mean something eventually, but not for the exam. Okay, let's see. What do we need to do to advance this? This one? This one? I thought this.
Just right and left.
Right and left, okay. Okay, question number 1. Which one of the following statements about this adrenal lesion is correct? The answers are on the sheet. Circle the one that you believe is true. Are you ready for the next? Or as ready as you will be? This is number 2. This image shows the salient biopsy features of a right lobe thyroid mass. Based on the features, which statement is correct? This particular image was not shown to you in lecture or lab. You've made a choice. This is the third and last image. This one actually doesn't even require the image. It's just a question about the parathyroid gland. All right, I'll give you the answers. You can put an X or whatever designation around the correct one. Number 1, the answer is C. Number 2, the answer is E. And for number 3, the answer is A. And we'll go over each of these in the sections. If you got it right, put your hand up. This is the equivalent of the graph. Can I see the graph? I see. It's okay. We'll work it out. All right, pituitary, the anterior and posterior lobes, located in the sella turcica, right here. So we have the, let's see if we can get this up. Right, here's the view. Remember, the most darkly stained colored area is the anterior lobe. The pars distalis and the pars nervosa is the closest that looks like nerve tissue. An adenoma is a mass-occupying lesion, so it creates symptoms by its location in this area of the sella turcica. And the cells in question that can produce these tumors are seen here. So we know what comes from the posterior lobe. The neurohypothesis is ADH and oxytocin. And here are the secretions from the anterior lobe. So 3 different colors of cells. The red ones, the acidophils, produce growth hormone and prolactin. The basophils, the blue ones, are the most productive: TSH, LH, FSH, ACTH. The lack of staining cells that have a bland, very pale pink cytoplasm are chromophobes, which are putatively exhausted of whatever secretions they make. So, here are the most important topics. Hyperpituitarism is usually due to what? It's usually an adenoma. And which one's the most common? It's a prolactin-producing tumor. And since, if we go back, the prolactin secretors are the acidophils. When you're getting these specimens in pathology, you're more likely to see an acidophilic mass of cells replacing all the other different forms. And you need to determine the secretion, if it's not clinically evident, by doing a variety of immunostains. The frequency after the prolactinoma is growth hormone and ACTH. Are they all encapsulated and, like adenomas, non-invasive? No, some of them grow out of the confines of a collagen capsule, so they can invade the cavernous and sphenic sinusoids and the brain. The mass effects are visual field problems, increased intracranial pressure, and occasional hypopituitarism from compressing the normal residual tissue. The prolactinemia has effects on menses, breast milk from the breast, loss of libido, and infertility. Key points. The most common cause of hyperpituitarism is anterior lobe adenoma. Most are sporadic. As with many of the diseases we use as examples, very few are actually familial. Symptoms we discussed: diplopia, altered visual field, headache, nausea, vomiting, etc. Changes radiologically in the cella turcica. The non-functional ones can grow to larger size because there's no symptoms until they are compressing something. The secretion, if it's not otherwise made itself known by physiology, is an immunostain process once we've resected the lesion. Prolactinemia is the most important type of secretion. Okay, now the adrenal cortex. Here's the lesion. The question was, which is correct statement? So let's look at the answers here. Most of these are non-functional. So if you get an adenoma growing from the cortex here, the large majority are not going to be functioning. Whoops, sorry. Incidentalomas. So it's found when an abdominal field is examined radiologically and you find a lesion in the adrenal. And this is from your lecture notes to remind you. Cushing syndrome has 4 causes. The most common is the lower right corner, exogenous administration of corticosteroids. Of the tumor lesions that cause it, notice that the majority are pituitary adenomas that cause what is known as Cushing's disease. So that's the release of ACTH from an adenoma of basophil cells. And then paraneoplastic is 10%. Notice there's a lung with a tumor in it. So there are, the small cell variety of lung cancer is occasionally presents because it's making a parahormone that it shouldn't be making, such as ACTH. And 10 to 20% are in a primary adrenal neoplasm. So for the question C, where it's, B, this is ACTH dependent. Remember, the only one that's operating on its own is the adenoma. So that's an independent lesion, not dependent. So here are the main points about adrenocortical lesions. The functional status can't be predicted from the gross or micro appearance. So the answer to D is obviously wrong. You can't tell from the gross if it's making anything. Primary cortical neoplasms cause 10 to 20% of endogenous Cushing syndrome. Functional adenomas are most often associated, however, with hyperaldosteronism, which is known as Conn syndrome. So in the association in answer E, cortisol doesn't jive with Conn syndrome. Cushing syndrome is correct. A viralizing neoplasm in the adrenal is more likely to be carcinoma. Pheos, what do we have to say about them? Well, they're in the medulla. They're very vascular, which is why they're this red. Notice the cortex is here and yellow. 10% rule, we mentioned this in the lab. 10% are in association with the multiple endocrine neoplasia syndromes, 2A and 2B. We're going to go over those at the end if you haven't seen those before. 10% are in extra-adrenal sites. These are neuronal sites where you have potential tissue that can give you medullary catechol-secreting secretions. What is the organ of Zuckerkandl? It's a small, referred to as a paraganglioma, located at the bifurcation of the large leg vessels in the aorta. There are carotid body lesions, paragangliomas, that can sometimes do this. And the third 10% is 10% are malignant biologically. The histology of them is not distinctive enough, but you can do assays of the urine looking for free catecholamines and metabolites as shown there if you're making a diagnosis. Most present, when they present, as hypertension, but it's only seen in half the patients with Pheos. You may have sudden death, obviously, if the hypertension is very significant. And the only way you can tell if it's malignant is if you find a metastasis. That's important. No histology, no gross features will help you on that. Waterhouse-Friderichsen, so we're talking about hypoadrenalism. This is infectious unless it's post-pregnancy, postpartum, when it's known as what condition? Sheehan syndrome. So this is bilateral adrenocortical hemorrhage. Meningococcal infection is a high candidate. Acute insufficiency. Patients present with DIC and purpura. Sorry. It's this one. And just remember that it is not limited to meningococcus. It sometimes can be other organisms. And we've seen patients who are elderly or who have primary splenic atrophy who, as a result, are not clearing certain high virulence organisms like strep pneumoniae, and they can get this occur through that process. And there are other physiologic effects, as you probably covered. And DIC is evident with all that hemorrhage into the skin. All right, now the question on parathyroid gland is an intriguing one. If you didn't get it right, the point is if you don't have an elevated parathormone level, you have to think of a different cause than the parathyroid. If it's primary hyperparathyroidism, whether it's all three glands, hyperplastic, or one adenoma, it's producing parathormone. If you're getting the effects and having abnormal fractures when you shouldn't, in a 50-year-old man in several vertebrae, not from a trauma, you have to consider a tumor and a malignant lung tumor. Which lung tumor? Squamous cells are notorious, squamous cell carcinoma, notorious for producing parathormone-like or related protein. And it acts to cause resorption of bone and then the fractures. So notice that the picture was just a normal parathyroid. If they resected something thinking it was the adenoma and the parathormone intraoperatively didn't go down or it was already low or undetectable, that wasn't the source. So normal parathyroids are half fat and half parathyroid tissue, and they're arranged in these island-like groups or lobules. When you have an adenoma, it's one cell clone that replaces everything, including most of the fat. So you don't see these islands or lobules, and this is an example grossly that was resected. So the normal size is this, and this is centimeters. So you see it's only, at best, 5 millimeters large, and then this thing is the adenoma. Here in the adenoma, the only part of the parathyroid that still shows fat is this little corner. This is the whole gland, and notice you don't see any islands, only 3 or 4 adipocytes. The rest is a sea of cells. These are the chief cells of the parathyroid, which make the parathormone. This specimen is inked with black ink, just in case, although it's rare, it turned out to be a parathyroid carcinoma. It would obey similar rules, basically, to what you've learned already about thyroid carcinomas. It would be extending through the capsule into the surrounding tissue. But it's extremely uncommon to get a carcinoma. Most common cause is a primary hyperparathyroidism and hypercalcemia. This is the order of things. Adenomas, the majority. Hyperplasia, where one gland being removed isn't going to do the trick, so you may have to take multiple glands out, 10 to 15%, and carcinomas less than 5%. Most of these are sporadic, not familial. The familial ones are weird endocrine syndromes that you probably at least heard mentioned. The multiple endocrine neoplasia, 1, 2, 3, and 4 we'll see at the end. And then this familial hypocalciuric hypercalcemia, which is rare. We're going to do MEN 1, 2, 3, 4 shortly. And because of the parathormone and resorption of bone and the calcium changes, you get changes in the bones, the kidneys with stones, and motility alterations because of calcium, and CNS effects. Moving to the thyroid gland, a large gland that has no significant nodule but is just diffusely enlarged is typical of hyperthyroidism and Graves' disease. All of it is normal appearing color, but just enlarged and very beefy red. When the gland is producing a lot of thyroid hormone and you have symptomatic hyperthyroidism, it means that in addition to making colloid, that is iodinated, it's resorbing a lot into the apices of the follicular lining cells. So every place, remember, the apex of each cell engulfs a little vacuole, endocytosis of T3 and T4, passes it down to the small capillaries under the follicle. This leaves little scallops, little bites. So if you see this field in somebody who's behaving as their hyperthyroid, that is the histologic correlation. Would a biopsy be necessary? Not. In contrast, a white, small thyroid is infiltrated by white blood cells until proven otherwise. And it's typical of Hashimoto thyroiditis, chronic lymphocytic thyroiditis, and hypothyroidism. What do we see microscopically? Just what you'd expect. It's an attack by plasma cells and T and B lymphocytes on the thyroid follicles. So you see large infiltrates of lymphocytes here, and notice there are gaps here where there are no longer follicles. They've been destroyed. When you look closely, there are some residual follicles that may be small, or a few cells that are very large and pink and granular. They're referred to as Hürtel cells. They're full of mitochondria, which is why they're granular and very pink, and they're the remaining follicle epithelium. So Hashimoto Hürtel cells, the two H's go together, hypothyroidism. Sometimes you even have germinal centers forming. What tumor might you expect is at a higher risk in Hashimoto's? Malignant lymphoma. right? So if it's a lymphoid infiltrate, you may have certain patients who will get a lymphoma. Goiter. So you're doing the neck exam and you feel one or multiple nodules. If the person has iodine deficiency, it will wind up looking like this eventually because you're not resorbing the colloid because it's not iodinated. These nodules that you feel are full of gelatin-like colloid. It enlarges each follicle and is not taken into the cell. Some can get so large that they rupture into the adjacent follicles and they break through capillaries, causing hemorrhage. And the hemorrhage later heals with calcification and fibrosis. So that's these areas. So a nodular, hard, calcified thyroid is very suggestive of nodular goiter. Here's one example where part of the gland was fine, and then you had three or four nodules, again with fibrosis, this very juicy colloid. And the microscopic correlate is the follicles get huge because they're not resorbing the colloid. So you see different variations in the follicle size. Small ones, smaller ones, and very large ones. That's the basic feature of a nodular goiter. Now the adenoma question, and you had one with in your little quiz just before, and this is their typical appearance. They're very well circumscribed, usually encapsulated, and homogeneous looking, tan or orange. Most are not functional, so will they be hot or cold on scans? Cold. And microscopically, they're small follicles and usually very uniform. Notice that the cells are cuboidal. The nuclei all look alike, and there's nothing distinctive in them. The key with the thyroid follicle epithelium is that there's nothing distinctive in the nuclei. This is one of the few organs you've heard about so far where nuclei means something to the pathologist in terms of determining whether it's benign or malignant. So, in the benign, you see all these little follicles. You have to carefully look at the capsule to make sure it's not invaded. It stops where the capsule begins. There are veins in the capsule, so you noticed in the last question you had, you can have either it invade the capsule itself or the vein. Either one is just displaying its biologic invasiveness. So these are the forms. Papillary is the majority, follicular is less, medullary is even less, and the anaplastic is the least common. So obviously you should know the most about papillary, and this is one of the questions. Number 2. So this is the gross. You won't see it, but surgical pathologists see it if it's resected. Instead of being that beefy red color, often you see a funny yellowish color, and it's very like little villi sticking up because it's got papillae. And here are the key findings. So growth, instead of follicles, now you've got these villus-like papillae. That's no good. If you have a thyroid biopsy or a thyroid gland resected or a lobe, little papillary structures are no good. Little orphan Annie nuclei. What happened to the picture? Too bad. Didn't get into the cut. So these are these empty holes in the nuclei that look like the comic strip. An alternative form are these coffee beans with a nuclear groove in the nucleus, but the one we really look for is the orphan Annie. Papillary carcinoma spreads to regional lymph nodes, so most of these answers in number 2 are wrong. What age group is papillary carcinoma? Your age group, not over 50. Answer B, biopsy shows typical picture of a benign goiter. Papillary structures are no good in any setting in the thyroid, period. If it was a goiter, you'd see varied size follicles. Answer C, The major risk is iodine deficiency, correct or not? What's the major risk for papillary carcinoma? Exposure to, in childhood, ionizing radiation. So this is what you would get out of a Chernobyl catastrophe, the Japanese catastrophe with radiation, or any other exposure. Lung metastases occur frequently and curtail the 10-year survival. True? No. That's follicular carcinoma, not papillary. Papillary has over 95% 10-year survival and goes to regional lymph nodes. And Psammoma bodies are an additional feature, and that's true. The Psammoma bodies represent these tips of the papillae. Remember, the tip of the stalk of this villus here is far away from the blood, which is sort of at the root. So some of these cells undergo necrosis, then they take up calcium and they become these whorls of dead cells that stain dark blue, Psammoma bodies. So any papillary tumors in any organ tend to make Psammoma bodies. One example is thyroid papillary, another is ovarian papillary carcinoma. So now we have another follicular lesion. So if you just have a biopsy, that's not adequate for making a full diagnosis. You have to have a resection and look at the capsule. So to determine if this is all follicular, no papillary structures. But if you look at the capsule, as in here, where the arrow is, the tumor has invaded the connective tissue capsule. So that's evidence of carcinoma in that particular case. And in the next one, clearly in the capsule, you've got a vein that's full of tumor, and it's all follicular. So that's also follicular carcinoma. And the MEN syndrome. So how many of you now have covered this? Was it mentioned in some of the clinical lectures? So I'll never remember these names. I have to look back at this thing every time we talk about it. The only one that you might remember is MEN1, which we'll look at in a second, not because of the eponyms or whatever they're called, wormers, sipples. It means combinations of multiple tumors in different sites of endocrine organs. There are now 4 subtypes, so they're subdivided into MEN1, 2, Sippel syndrome is MEN2, which is 2A. 2B is MEN3, Wegenmann-Froboos syndrome. And the last one, which I thought was the more interesting, because you know that pathway, is MEN4, which is the latest discovery, which is a cyclin D kinase mutation that prevents you putting the brake on cell proliferation. So this is type 1, the 3 Ps. That's the one most people usually remember. Pituitary adenoma, usually prolactinemia. Pancreatic islet tumor, so you can either get one that's producing insulin with hypoglycemic episodes as the presenting sign, or gastrinoma. This is gastrin producing, so you get these terrible ulcers in the stomach, and that's called Zollinger-Ellison syndrome. And finally, a parathyroid adenoma, which we've discussed, so it's a parathormone producing, and that's the most usual presentation of type 1 MEN. The genomics of this are now known, so there is a tumor suppressor gene called MEN1, whose gene product is menin, and this is mutated in MEN1. MEN2A is Sippel syndrome. So this is medullary carcinoma. So here's a picture of medullary carcinoma, which looks different, of course, from the thyroid papillary. So no papillary structures. Here's the tumor amidst the thyroid gland. No follicles, no papillae, just a sea of cells, and there's calcitonin-producing cells. So we have medullary carcinoma, parathyroid hyperplasia. So here we have all 4 glands hyperplastic, coupled to an adrenal pheo. This one has a germline gain of function in the RET oncogene. And the newest one, I won't go into MEN3, but 4 is the one with cyclin D kinase, and this has pituitary adenoma, parathyroid adenoma, and then another tumor in the lung, bronchial carcinoid, or a tumor in the pancreas. So that's it on that, and just a few brief comments on placenta. As I said, I wouldn't waste any time going over this pictorially because I don't think there are any questions. Clearly, we saw normals with translucent membranes, and anytime you see cloudy yellow membranes, you're talking about chorioamnionitis. Here is a summary of the lesions. Remember that the maternal surface, the decidua on the endometrium, may control a lot of the placental abnormalities during a birth. So vascular diseases need to be under control, including diabetes, hypertension, smoking, drug abuse, cocaine. All of that impacts on a growing infant. There can be problems with the villi. So the villus problem is the mole. That's the cluster of grapes lesion, which we'll see in a moment. There can be problems creating the amniotic fluid, and one of them is having too little fluid. The baby's growth is impaired, and that's called oligohydramnios. The cord insertion, if it inserts in the membrane instead of into the disc itself, that's called velamentous, and this can be located down here and lead to vasoprevia and vascular accidents. The discolored placental membranes is chorioamnionitis, infection, and it's usually ascending through the vaginal vault, not hematogenous spread. Umbilical cord abnormalities. Single artery, normally it's 2 arteries, 1 vein. Nuchal cord. We had one case about 4 years ago where, unfortunately, the infant had absolutely normal prenatal care up until the end, and then the mom didn't feel any movement, and that baby had a cord that was totally wrapped around the neck, and the baby strangled. Infection that proceeds up into the cord is called phenycitis. And we had the abnormalities of the placenta itself. This is chorioamnionitis, which we saw, discolored membranes. The organisms are listed there: beta hemolytic strep, mycoplasma, gram-negatives. The membranes, when sectioned, show neutrophils. Normally the membranes are the amnion, the cuboidal epithelium, and the underlying chorion, which is connective tissue with no inflammation. The placental problems. Previa. Placental implantation is in the lower uterine segment. It should be up here. Why? Maybe there was a previous C-section that altered the surface for implantation. It may have been an overly excessive curettage for an abnormal episode of menstrual bleeding, or it could be cocaine use. The complications of this, you may have hemorrhage, or you may wind up having an early C-section because it's lying too low in the cervical os. Then we have abruptio placentae, which is retroplacental hematoma. Here we have a hematoma that's developed between the placenta and the decidua, and this is typically a blood vessel rupture. So you have to consider, why would a blood vessel rupture here? Maternal hypertension, preeclampsia, uterine vasospasm, and arteriole ruptures, or cocaine use, which is, of course, a vasospastic agent. You can lose a child to this if it's large enough. You might need to do a C-section, but many of these are just incidental. If they're small, you find them in examining the placenta at a normal delivery. And finally, we have the accreta. This is where there's not a nice bed of decidua, shown in yellow, in an area of the surface. It has either been removed from a previous dilatation and curettage for an investigation of abnormal menses, or some other reason for scarring. And it could have been that the placenta was previously down here, and it led to an abnormal scar. So this can cause bleeding, can cause uterine rupture if it's exaggerated. If the growth of the placenta is right through the wall, that is called placenta percreta, and that, of course, can lead to rupture. And if the bleeding is severe and you cannot remove this successfully, you may have to do a hysterectomy. The specimen we saw in the lab was a hysterectomy specimen where it just could not be removed and there was excessive bleeding. This is without any other instruction, typical of a mole. If that's what the placenta looks like, you know you're in trouble. There's no disc, there's no cord, there's no fetal parts in one form, the complete form. In a partial, you may create an arm or a hand or a foot, but no complete fetus. So this has to be evacuated. It's obviously going to appear on ultrasound before you even get to a full gestation. The key is the villi are totally dismature. They're huge, edematous, broad. They look nothing like mature villi. The only reason to cover moles, in principle, is to look at the arc of potential diseases. 90% are benign, and they're just evacuated, and you try again. 10% invade into the wall, so they're more aggressive lesions, and then a small percent, 2.5%, wind up being truly malignant, and they're called choriocarcinoma. The surface of the villi is cytotrophoblast and syncytiotrophoblast. Those are the malignant cells in choriocarcinoma. That tumor has the potential to widely metastasize, but thankfully it's a small percent. And that's the end. Good luck and have a great summer. How many people are staying on campus, do you think?
Probably
Yeah.
most of them doing research.
Yeah. You're going to be where? In the DR? With Dr. Nicholas?
Yeah, that's part of my.
Oh, nice. Well, that's good.
Sorry that the slideshow.
Yeah,
was
it
imperfect.
was,
There probably was a better way to do it,
yeah, but
it worked.
it was fine, I think.
Yeah.
My error. I could have
I should've-
sworn. Oh, I know what happened. I
Should
think
have probably
what,
had it like this.
oh.
Okay.
I was going to take it out, and then I know what happened. I had a PowerPoint open, and it won't let you take it out of your computer if you've got an active PowerPoint open. And then I was interrupted by something. Anyway, thank you for